Good afternoon, everybody. This is the second and last presentation that we are going to have from Dr. Panos Kanavos. Panos, as I said, is a professor at the London School of Economics and has been collaborating with PAHO on for a while, and without repeating myself in the morning, I think this particular section we're going to devote to the results of a large project that was headed by the London School of Economics by Panos on health technology, advanced health technology assessment. It was financed by the European Union FP7 framework, and PAHO and the Escuela Andaluza de Salud Pública provided a particular work package, how you define it, and I think we are going to hear about the results, which I think are very interesting, and then the comments of how this directly applied to the results in the Americas. So without further ado, Panos, once again, thank you. We have abused your knowledge today, so that's good. And before we think, there are more than 10 institutions connected, so I don't know how many people, but I've seen our colleagues from Colombia and different countries, so good afternoon to everybody, and thank you for being connected.
This is great, and good afternoon from me. So I wanted to say, we've got about an hour or so, give or take. So I wanted to spend this hour talking to you about the Advance-HTA partnership, which is a project that was funded by the European Union, the European Commission, over a period of 3 years. And the aim was to basically improve methods, or if you like, advanced methods, in health technology assessment. And the rationale for this was a specific agenda that was outlined in the European Commission's call for proposals. And the Commission took into account the fact when putting out this call for proposals that there are significant gaps that we have in health technology assessment, particularly as they relate to HTA for orphan medicines, HTA for medical devices, the broader issue of value assessment. In other words, what criteria do we use and how these criteria blend with traditional criteria on economic evaluation, whose preferences are elicited and the extent to which you can elicit preferences from not from society or the average citizen, but preferences from patients. And last but not least, an additional dimension which we took into account was how is HTA applied in emerging country settings. So these are some of the key trends that we are taking into consideration in an attempt, if you like, to respond to these terms of reference and provide a meaningful backdrop to the proposal we developed back in 2012, and obviously now the project has ended and we are leveraging the results in a multiplicity of ways, including publications, presentations, and further dissemination. So, of course, we're taking into account, and the Commission's view in terms of putting the call for proposals out was related to the challenges for sustainable financing, the suggestions that health technology assessment perhaps need to change to a process which is more iterative and more deliberative as opposed to purely assessing cost and clinical evidence. The fact that we probably need to reflect more on methods of health technology assessment beyond HTA methodology itself in order to address issues of affordability, and so on and so forth. So these are some of the key trends we are experiencing. Now, before getting into the Advance HTA partnership, I just wanted to share with you a brief taxonomy that we have developed based on a systematic literature review that summarizes the options for the sustainable finance of innovative therapies. So we did a systematic review just to identify some of the options that we have available as decision makers and in different settings. And this taxonomy relates to a number of things. First of all, healthcare programs that ensure, by and large, that budgets are, continue to be capped. So for example, in this context, we have seen not only in Europe and North America, but also beyond. But some of the examples that are shown here are drawn from Europe, North America, and probably the rest of the OECD countries. We've seen financial support programs, we've seen patient education programs, we've seen special population programs, national and regional plans, for example, the action plan on hepatitis or the plan for combating antibiotic-resistant bacteria and so on. We have seen extensively disease management programs which effectively are looking at containing the rate of growth of expenditure and in some cases also offering savings to healthcare systems. A second dimension of the options for the sustainable financing of innovative therapies relates to pricing and funding models. And remember, as some of you heard me speak earlier today, there's a multiplicity of options around managed entry agreements, and we've seen how these work in practice earlier on. The special funding arrangements, for example, the early access schemes that we described in France and in the UK, there are priority funds, there is central purchasing, and I've put some of the work that we've done here at PAHO in this category. But there's also there are also experiments with social financing. For example, the whole work around social impact bonds and health impact bonds, and we've seen applications of these in certain jurisdictions. We've also seen calls to experiment with tools such as the drug mortgages, which is more of a model which relies on a financing option involving a financial intermediary, healthcare system, and a solutions provider, whether that solutions provider is a pharma company, a medical device company, or in fact a disease management provider. And the third area, which relates to potential options for the sustainable financing of innovative therapies, is associated with financing mechanisms linked to intellectual property. And here we've got a huge agenda to explore, like prizes, and for those of you engaged with the UN, the United Nations debate about treating innovation as a prize, in other words, providing the innovator with a lump sum at the end of the discovery and marketing process, and making the innovation available generically. So that kind of discussion is beginning to come back after a few years, I would say quite a few years, of sluggish development. We've seen health impact funds and payer licenses, open source initiatives, patent pools for medicines. We've seen public-private partnerships in R&D. And one of those public-private partnerships is the IMI. We've seen discussions around corporate bonds to fund innovation, market exclusivity extensions, and priority review vouchers. So all these items relate to a broader skepticism that we have in the development of and financing of new technologies, and stretch beyond health technology assessment. So in trying to basically reflect on the issues surrounding financial sustainability and the agenda that I described earlier in terms of the unanswered questions in the context of health technology assessment, these are the 6 bullets that the Advance HTA project is trying to address. First of all, how do we treat value for money? Second of all, whether we can develop different types of frameworks that improve the quality of evidence required for different medical technologies. In other words, a value assessment framework. Is economic evaluation the only, let's say, set of dimensions that we take into account, and how can we incorporate other value dimensions? Is it worth eliciting preferences from patients rather than broader citizenship? Does HTA, the way we know it today, apply to medical devices across the board? And in what ways can we improve capacity building for health technology assessment in settings outside those that we know HTA works reasonably well? So these are the 6 broad questions that we are seeking to address. And ultimately, through this, contribute to the advancement of methods and practices of HTA in Europe and beyond. So this is the project. You will see that it is structured around 9 work packages altogether. The important ones, in other words, the items that have generated, the work packages that have generated significant outputs are 6, and these are highlighted in blue. So there's a work package, for example, on value for money, a work package on value assessment, a work package for rare diseases and orphan drugs, and a work package for preference, elicitation, and quality of life, 1 on medical devices, and 1 on emerging settings. Now, all these work packages, the 6 work packages, come together with concrete implications, policy implications, and recommendations in a different work package, in work package 7. And work package 8 was more about dissemination and coordination and management, respectively. And I must say, dissemination is always a very important element of the work that any European project funded by the European taxpayer. So it's an important dimension of all these projects. And we proposed and we did deliver 4 workshops in particular, 2 in the region here in Latin America, 1 in Mexico City and 1 in Santiago of Chile, and 2 in Eastern Europe in the last 2 years of the grant, in 2014 and 2015. So it was more about capacity building, about dissemination of the results that we achieved. So this is the project here. It is a large project. It was a very large project. It was a consortium of 13 members, which made, obviously, life not easy in terms of coordination, but a pleasure nevertheless, because different partners bring with them different perspectives. So there are 8 universities. There are 3 HTA bodies. The HTA bodies of England, of Sweden, and of Poland. There was a patient and professional organization, the European Brain Council, that brings together patients as well as healthcare professionals, particularly physicians. And of course, there was PAHO. That helped us not only disseminate some of the project findings in Latin America, but also helped us tremendously in terms of conducting the work package 6, which was more about HTA in a particular setting, in collaboration with the Andalusian School of Public Health. And the remit of each organization was different. PAHO helped us a lot in Latin America, given the expertise and the network in this region, and the Andalusian School helped us a lot in Eastern Europe. So you will see a lot of different partners from the UK, from Spain, from Italy, France, Germany, Sweden, Poland, Slovenia, and so on. So, and that's the beauty, if you like, of a collaborative project stretching across different countries, different regions, but also incorporating the views of different stakeholders. It would have been an oxymoron almost to have an HTA project on methods without having, for example, the participation of key decision makers from the countries, so HTA bodies themselves. It would also have been an oxymoron not to include the views and perspectives of healthcare professionals and patients, as you will see in a minute. Now, some of that information can be seen in terms of results, in terms of some of the project presentations, and increasingly some of the publications that we have come up with in the project website, which is here for your information. So let me share with you a few of the items that we have created in this context here, starting with Work Package 2. I'll go increasingly into Work Package 6, and then maybe Alessandro can talk about Work Package 6. So the project itself resulted in a number of in the production of a number of toolboxes or toolkits or frameworks or value assessment frameworks in this particular case. So Work Package 2 was about value assessment, and in particular we wanted to explore something which was, if you like, more of an academic pursuit in the literature up to 2011-2012. And here we're talking about multiple criteria decision analysis. The use of multiple criteria decision analysis had not been explored in the context of health technology assessment, so we're probably the first group, the first consortium that does that specifically and meticulously, if you like, also with the creation of a framework alongside a number of case studies. But why multiple criteria? Because it is a comprehensive methodology. And as I mentioned in the morning, there are several more dimensions of value that decision makers are including in the process of decision making on an ad hoc basis. It's a transparent toolkit where we have a very clear process for judgments to be made. And it's an encompassing toolkit. In other words, we include the views and perspectives from different stakeholders if our process allows. But the process of inclusion of different stakeholders is always context specific. In other words, we want to incorporate views, perspectives by, let's say, clinicians or economists or health economists or HTA bodies if the decision-making process allows that kind of deliberative process. Okay. And the reason why we pursue decision analysis, because it's a very convenient tool, because the beauty of decision analysis is to effectively disaggregate any complex problem into specific sub-problems, identify the specific sub-problems individually, and then aggregate to come up with a solution, if you like, to the overall problem itself. Now, if we compare cost-effectiveness analysis as a key means of conducting HTA, there's a fundamental difference between cost-effectiveness and multiple criteria. You can see that in this slide here. If you focus on the upper part of the slide, you will see that whereas in cost-effectiveness analysis, we include costs and health gains explicitly to arrive at a cost-effectiveness ratio, and then in the decision-making process, we are considering a number of trade-offs. Well, these trade-offs are other gains or stakeholder views before arriving at a decision. We consider these trade-offs implicitly in a discussion in a non-structured way most frequently. When we pursue MCDA, we consider not only the costs and health gains, but all the additional gains and stakeholder perspectives explicitly at the analysis stage. And then when it comes to a decision, then we have all these trade-offs ready and available for us to be discussed and for a decision to be reached. So in other words, MCDA facilitates, if you like, decision support. Now you can probably access this particular piece of work that we've done in Pharmacoeconomics 2016. It is available as open access. and effectively describes the process and the model that we have developed in this case, which is structured around 5 phases. We decide on the problem, we build a model, we assess the model, and we appraise it before coming up with a series of action plans. That process itself may not be too dissimilar from a typical cost-effectiveness model in the context of health technology assessment. But obviously the way we go about it is fundamentally different. So, for example, in problem structuring, we decide on what the problem is, and I'll show you a case study in a second. Okay? So this relates to one of the case studies we have done as part of the project. Which metastatic colorectal cancer treatment to cover? If we have 3, can we cover all of them, or how should we go about and make a decision about which one to cover? So the other thing is to basically put the problem into a particular context, and that takes us into the domain of what approach we need to follow. So in this particular case, we conducted a workshop with NICE, the English HTA body. And the third element here is to decide who are the stakeholders. Well, if we adopt a NICE approach to decision making, appraisal, evaluation, assessment, and subsequent decision making, then the stakeholders are the wider stakeholder community. In other words, the ministers, if you like, the HTA body, the clinicians, the patients, society, and so on and so forth. Now, the next item, and I'll speed up in a minute, is how to build a model. And here, what we need is criteria that are important in this context. We need to populate these criteria with attributes. In other words, if a particular criterion is overall survival, then we need to say, well, what is the standard of care versus the new therapy? So let's go back one. In assessing the model, then we have to pursue something called scoring. In other words, we score the criteria, then we ask in a decision framework and in a decision workshop, what people think are the scores for a particular criterion, and we follow that process throughout. And eventually we're asking people to weigh these criteria, in other words, to tell us how important they think each criterion is relevant to all other criteria. Okay. So in terms of building a model, we've come up with a generic framework that centers around 5 clusters of benefit, or 5 clusters of value, if you like. The first is the burden of illness. The second one is the therapeutic benefit. Third one is safety. The fourth is the innovation level. And the fifth one is the socioeconomic impact. Now, different decision makers are likely to have different reactions to each of the clusters and each of the criteria within these clusters. So, for example, some of them may score very highly overall survival if we're talking about the therapeutic benefit. And if we include quality of life, in some cases, some people may score quality of life higher than the overall survival, depending on the magnitude, the size of each of the criteria. The big question, of course, is how do we come up with the criteria that we see here on the second row, an example of which we see here on the second row. It's a complex process. It's a process of literature review. It's a process of consultation with patients, consultation with decision makers, and so on, and part of the dissemination process as well. Okay. Now, in terms of the model itself, then obviously we have to make selection of the criteria themselves. We don't want something, a model in other words, that gives us hundreds of criteria. We want something fairly robust and parsimonious. And parsimonious means that it has to be something fairly contained that captures significant variation of what we think is benefit and value, whilst we're leaving everything else that may be of some marginal importance but would not necessarily count in the final outcome. Now, as I said, scoring and weighting is and weighing is very, very important. So everyone needs to score the criteria and then derive weights. And the weights are derived based on individual reflections on how important people think are the criteria relative to each other. Okay, so we've done a number of case studies. The colorectal cancer one was one, the prostate cancer was another, and in the case of rare diseases, myelofibrosis was a third. And we're pursuing a number of HTA bodies, whether they are in England or in Scotland, and case studies with the Belgian Health Authority, the Polish Health Authority, the Dutch Health Authorities, and the Health Authority of France, just to see how they react to the model itself, the criteria, and how they weigh the score and the different options. What we're coming up with is really a cost-benefit kind of analysis, whereby we rank the different options, and this is reflecting the cost, the average cost, and the overall value of different therapies. In this particular case, for metastatic colorectal cancer, cetuximab, panitumumab, and aflibercept. And we are coming up with a unit of measurement which is cost per unit of value. So we think that this potentially could be a substitute to the HTA process, subject to some fine-tuning, which we are pursuing now with individual HTA bodies in Europe and hopefully beyond. It can produce a kind of cost-benefit analysis for individual therapies. It is important because to consider an alternative model to the traditional HTA approach because of flexibility, because of comprehensiveness, and because of transparency that we know decision makers actually want in most settings. But of course, what we have to come up with, and I think we may have done so far, is a fairly robust methodological approach that relies very heavily on principles and methods rather than on something which is airy-fairy and does not withstand empirical scrutiny and theoretical scrutiny. That's one of the toolkits that we have created with application in a number of areas. The second toolkit relates to orphan medicines and the kind of tools that we may want to create to assess benefit in the case of orphan medicinal products. The starting point here is that the orphan medicinal products are not cost effective unless society is willing to pay more, and that holds across the board. And what we have seen in most settings is that the incremental cost effectiveness ratio is way above any notional or actual threshold, and of course that there are significant uncertainties involved in the type of evidence that a manufacturer actually generates as part of the assessment process, whether it is a regulatory process or in fact the HTA process itself. So, and the question then becomes, is there something that we can do to basically enable us to come up with a different framework to assess the value of orphan drugs, either on an ex ante or an ex post basis? Okay. So, in order to address this particular question, specifically, are there ways are orphan drugs being treated differently from an HTA perspective, and what are the specific criteria driving recommendations on HTA in orphan drugs? We developed a model which is based on mixed methods research design, and we started with a case study, a pilot study, if you like, which enabled us was a drug indication pair evaluated across different settings. And that gave us a little bit of an understanding of the criteria that different decision-making bodies, HTA bodies, use to evaluate this particular drug indication pair, this particular therapy. there was the stage 2 in the process with qualitative data collection, and there was a stage 3 in the process involving quantitative data analysis. Again, following a mixed methods research. The outcome, of course, here was to arrive at a methodological framework enabling the systematic comparison of HTA decision process across countries, drugs, in this particular case, orphans, and of course a larger sample when we apply this particular framework to a larger sample of orphan medicinal products. Now, what is important in this case, and I alluded to earlier on in the presentation this morning, was that we came up with a three-pronged approach. The first one was to look at the evidence that was submitted or is being submitted as part of the assessment process. The second relates to the interpretation of the evidence and the uncertainties and other considerations that may be important in this case. And the third one is really the factors that lead to an HTA recommendation. And what we know is that the evidence is very frequently inadequate, incomplete, or imperfect. That the interpretation of the evidence and the HTA recommendation relies very heavily on value judgments. So we wanted to identify what these value judgments were and what differences were made across settings to interpret, in interpreting the same type of criterion. So when looking at evidence, we looked at preferences in the type of evidence and basically whether there was different evidence being submitted in different jurisdictions. In the interpretation of the evidence, we looked specifically at uncertainties that prevailed across the board. And in HTA recommendations, the factors that may have influenced preferences of decision makers in different settings. So here's the sample of medications, orphan medicinal products, and the respective indications. And 4 of the 11 countries that we looked at very specifically to identify the reasons for rejection, but also the reasons for acceptance. Okay, I think I'm going to go faster. So basically, we created this particular framework in terms of evidence. If you look at the tool that we have developed here, the primary trials, we have different levels of appraising the same trials in different jurisdictions. And if you're looking at non-primary trials that were frequently submitted as part of the deliberative process, there is very frequently different acceptability. So in other words, using indirect comparisons, different acceptability or different requirements. Or when using observational data, different acceptability by different HTA bodies. In terms of the interpretation of the evidence, whether this concerns other considerations, uncertainties, or stakeholder input, this is where there was significant lack of agreement in interpreting and dealing with the same evidence. So it is really an issue of interpretation. And in terms of influence in the final decision, yes, there were significant other considerations that apply to the disease, as I alluded to earlier on this morning, specific considerations that apply to the disease, but also to the drug itself within the indication. Now, this particular tool here is more of an ex-post assessment of, let's say, decisions based on 3 dimensions where we think important variation exists across HTA settings. The big question is here, how useful do we think this is for decision makers? I think it can be useful in a number of ways, particularly if the sample of medications is large. So in other words, we don't have 35 or 40 that we have at the moment, but if we have over 100 drug indication pairs, then we can make inferences about the kind of factors that contribute positively or negatively to a particular decision in a particular setting, and what are the factors that trigger a positive decision in one jurisdiction and a negative decision in another. So, in other words, we can use this information in a predictive way to derive, if you like, preferences of decision makers across settings. Another, in my mind, critical element which was part of the research agenda was quality of life measurement. And the starting point for this particular work package, which was run by ourselves at LAC&CEE and the Institute of Economic Research in Slovenia, was to improve the robustness of evidence on preference elicitation by deriving those preferences in settings which are more relevant in this particular case, the patient community, instead of citizenship. And in that context, we had to go out to the patient community and actually replicate the process of preference elicitation to patients rather than society. The tool that we used in this case was the EQ5D. I guess most of you may be familiar with EQ5D. So think of the EQ5D 5L, the 5 levels, to be administered on a face-to-face basis to a sample of patients rather than a sample of random citizens. Okay? The hypothesis that we tested was the following, that there were differences between patient and population preferences due to adaptation of patients to health states. Okay. I will tell you what happened eventually, but in fact we did find that there were differences, but not due to adaptation. Those who adapt to new circumstances have high utilities to the surrounding hypothetical health states compared to the general public. Again, we have found some evidence to that effect. Now, clearly, we couldn't select the entire EQ5D 5L health states because we're talking about hundreds here. But we did select a number of dimensions where we thought that could make a difference. These are highlighted in yellow here. So we selected these. Now, importantly, and if you look at the bottom right-hand side of this particular slide here, looking at the visual analog scale, the value of utility in the general population is 0.82, give or take, depending on the setting. The value that we found from patients, and I'll explain that in a second, what patients and where, was 0.75. Now, clearly, this difference here is significant and also statistically significant. In fact, we know that for utility values to have a clinically meaningful and statistically significant impact, we're looking at 0.3 to 0.4, 3 or 4%, in other words, changes or so. Now, we did a number of interviews, 300 or so per indication, across rheumatoid arthritis patients and breast cancer patients. The setting we selected was Spain, because at the time of we conducted the research, the values on EQ5D 5L from a societal perspective were available, and we could compare like for like directly between the sample of patients that we interviewed and the sample from the values from society that were already available. So the big question was, are there differences, and are these differences significant and meaningful? Well, there were no differences between patient groups, whether we're talking about breast cancer patients or rheumatoid arthritis patients. So you can see the comparison here, general population versus patient, rheumatoid arthritis versus breast cancer. You can see there are no differences. But there are significant differences, and in fact statistically significant differences between the general population and patient groups, whether these differences relate to the patient irrespective of diagnosis, or the general population versus rheumatoid arthritis and the general population versus breast cancer. So some of these differences were significant. We can see the individual, in this slide, the individual health states, or at least a subsample thereof, and between patients and the general population. You can see that some of these differences are significant, either for these dimensions here or these dimensions down here. The differences where we find significant, the dimensions where we find significant differences were three in particular. So they're related to mobility, the dimension of pain or discomfort, and the dimension of anxiety or depression. So these were clinically, these were statistically significant differences across across patients versus the general population. So that made us conclude that it may be necessary for resource allocation purposes to increasingly use patient values within a specific diagnosis rather than general population values. General population has a tendency to overreact, maybe to overpredict and overplay, if you like, in a particular health state, whereas a patient, we found that there's no adaptation to the process, there's no adaptation of a patient to a particular health state. This has obvious implications for resource allocation. Because imagine if you have an incremental benefit in a new therapy and you measure utilities within patients, it is likely, in fact it's more likely than not, that the incremental therapeutic benefit will be valued very highly by patients because they're experiencing a particular health state versus society where the actual benchmark values of utilities is already very high. And it may be the case that this may actually want us to rethink cost effectiveness and ICERS in general, partly because the ICERS that we have at the moment may have been over measured. In other words, the values may be X, whereas the values could be X minus a particular proportion. So there are obvious advantages. The challenge, of course, is to select individual patient numbers and patient cohorts every time we have a particular new therapy and measuring its incremental value. Okay, so this could be seen more or less as a pilot case study in two therapeutic areas. Work package 5 was about medical devices, and this is probably, and I would say par excellence, the area in health technology assessment where we do have significant differences in our knowledge and understanding of how HTA can be conducted and what the outcome of an HTA in medical devices is. So the purpose of this particular work package was to first of all develop, if you like, a taxonomic model that would group HTA, that would group medical devices for HTA purposes. And we will use specific classification schemes. Medical devices are totally different compared to drugs in a number of ways. One of those ways is really the type of evidence that we have available when making a health technology assessment. Another is that the spread that we have of medical devices varies quite significantly, in fact, enormously. So we're talking about medical devices ranging from big ticket items such as MRI scanners or CT scanners or PET scanners, really investments running in the millions at the top end, versus stitches and sutures, which are practically, the unit cost can be a few cents. Yeah? So the question is, what is it exactly that we are doing? Are we looking at medical devices such as big ticket items? Are we looking at something which is generically available and costs on a unit basis a few cents but has large budget impact? Are we looking at something different? Okay. So the purpose of the taxonomic model, therefore, was to map things out and then select a few areas where it will be meaningful to do methodological work. Now, this is a fairly complex, if you like, table, but it gives you an indication of the complexity of medical devices themselves. Now, on the rows here, you have taxonomies that we use in Europe, and I suspect in other geographical jurisdictions, whether it is the United States or Australia, or I suspect Brazil, and maybe Alessandro can tell us all about it later on, if possible. We have a number of taxonomies, we have a number of regulations, but look at the kind of differences that we subscribe to each box here. Assistive technology devices, artificial body parts, medical devices for the assistance of medical professionals, assistive technologies, devices, body parts, and so on and so forth, whether these are diagnostic or in fact therapeutic. With some examples here about what kind of device we are talking about. And that, of course, shapes by and large entry of new technologies, the entry space of new technologies, but also the kind of evidence that may be available at some point downstream to effectively enable us to assess the incremental benefit and potentially cost effectiveness of different devices. All right. So we therefore did a systematic review and a significant process thereof, where we looked at probably several hundred, if not more than 1,000 pieces of evidence to try to understand and map the environment and focus on some of the diagnostic devices themselves. So we saw that as an opportunity to map the environment for medical devices, to obtain and to provide rather insights to legislative work, regulatory work that is currently taking place in Europe. We saw that as an opportunity for this particular piece of research to inform the process there. We saw it as an opportunity also to, for this work package to serve as a support tool to select key topics for assessment later on, to understand the type of evidence that may be available to, for researchers, but also HTA bodies, and so on and so forth. That was work package 5. Work package 6 that Alessandro is going to talk to you about was very challenging, because it looked at 2 very specific geographical regions with a specific remit to understand HTA processes, but also produce a hopefully meaningful toolkit that would enable decision makers to look at evidence and look at HTA and its implementation in each of their settings that we had in mind. The 2 settings were Eastern Europe, where there is significant uptake of HTA, and of course Latin America. So PAHO's role in this context was, I would say, critical and pivotal. Alessandro?
Okay, thank you. As Panos mentioned, this HTA emerging settings, we have on one side Central and Eastern European countries, and on our side, and the Central American and Caribbean countries, and also we included some of the REDETSA countries, as I will explain in a few moments. So let's try to use this mouse. It's not very easy. Maybe Francisco is more better skills than. Yeah. No.
Okay.
Definitely has. No. We have to put it other one.
Anterior, no.
Okay. Yeah, 25 slides, 10 minutes. Yeah, I can do it. So thanks to Fernanda Lessa, Francisco Cacao for all the hard work. And so I think this the HTA in emerging settings, as Panos mentioned. It was coordinated by Escuela Andaluz and PAHO, and of course we have the collaboration of Panos, the whole team of LAC&CEE, and also from NICE International. The three deliverables of this working package was mapping existing HTA capacity and decision-making process in Central Eastern European countries and Central American and Caribbean countries. Of course, we're going to focus on the region. Case studies on decision-making informed by health technology assessment, and the toolbox on best practices and recommendations on HTA implementation. Start with the mapping exercise. In fact, we have two components for this mapping. The first one on HTA capacity, and second one on HTA and decision-making processes. And this was a partnership, in fact, between the Advance HTA Project and the REDETSA members, since one of the tools was developed by REDETSA to use, we use it first in the REDETSA countries, and then we adapt the tool for using in the Advanced HTA countries. And for the HTA decision-making processes, it was the opposite. So the tool was developed as part of the project, and then we use this survey to for the REDETSA countries. So we send the service for Ministry of Health, HTA institutions, and other institutions. Those are the REDETSA countries and the Advanced HTA countries. You can see in the slide. And in the end, we mapped 31 countries in the region. We have a very good response rate, 89%. In the end, we received 147 responses. We identified 11 countries with HTA units or commissions or institutes or any kind of body that work with HTA, and 86 institutions that inform having carrying out some kind of HTA related activity. We're not saying that all of the 86 institutions are performing full HTA studies, but doing some kinds of activity related to HTA. Those are the results in terms of we ask countries if they have a formal HTA body or if they perform the HTA. As you can see in the slide, some of the countries, especially those are in the left-hand side, some of them mention that they don't have HTA bodies. Most of them do not have HTA bodies, but they perform some kind of HTA activity. For example, selection of medicines. Some of the countries in the Caribbean have pharmacotherapeutic committees that are doing the selecting medicines based on evidence. So this is related to the HTA. So they inform that even though they don't have a HTA body, is formally established. In the right-hand side, the REDETSA members, as will be natural, most of them has established some not exactly the HTA agency, but HTA entity, so a commission, unit, department, or any kind of institutions that are carrying out HTA work. So these are institutions that respond to the questionnaire. It's in the yellow here, the ones that are 73% of the sample responded that are performing some kind of HTA work. Canada here is in fact Quebec, the province of Quebec. That's why we don't have it is supposed to be so that's the explanation why it's the fewer institutions, because we work with the INES, that's the HTA agency in Quebec, that's member of REDETSA. That's the explanation. But in the other slide, you can see the documents, the outputs related to HTA. Then, in this case, we decided to include other provinces, especially the national agency, that's the CADF, and also the Quebec agency. So you can see the documents, HTA reports, is the country with the highest number. But also Argentina, Brazil, Colombia, and Mexico with significant production of HTA-related documents-related outputs. Mexico specifically on the clinical practice guidelines. When asked the decision makers and about the main barriers for HTA implementation, and the 22% responded lack of qualified human resources, lack of funds, and also lack of incorporation of HTA as a tool for decision making. When you ask about if is decision making informed by the HTA, and here you can see the difference between the advanced HTA countries and the REDETSA countries. I think most of the time, so half of the REDETSA countries say most of the time decisions informed by the HTA. Only 24% of advanced HTA countries mention that they use HTA most of the time. But when we ask about explicit links, we wanted to know about the legal framework. If there's a legislation establishing the use of HTA, then we have we can see that there's a gap in terms of the explicit link between HTA and decision making. So you see that 36% of the advanced HTA countries, they say there's no link and the decisions are not informed by the HTA. So there's a very important gap that we can, you have to work on bridging this gap in terms of using HTA as a tool for decision making. When you ask about the methodological guidelines, I said in the region of Americas, it's most half and half the country using HTA guidelines. But as you can see here, there's a huge difference between the REDETSA countries and the advanced HTA countries. Basically Central American, except Costa Rica and El Salvador, that are members of REDETSA, and all the Caribbean countries that were part of the project. None has HTA guidelines implemented, so that's a concern. In terms of implementation, it's interesting because when you ask about if an economic evaluation required for the decision-making process, surprisingly, more than 50% of the countries say yes. This was surprising. But when you ask about methodological guidelines, 80% responded no. So this is quite surprising and subject to further research. But I would like to draw attention for this question in terms of monitoring the implementation. Are there monitoring mechanisms for assessing the uptake of technology recommendations? Basically, if they, we talked this before in the other session in terms of monitoring the implementation of decisions. And almost 70% of the countries responded that they do not have any mechanism for monitoring the effective implementation of the decision. So this is a really important gap. In terms of using HTA reports and evidence and reports produced in other jurisdictions, and some of them, the countries mention NICE, mention CADIF, the Canadian Agency for HTA, and that's impressive, the percentage of countries that are using HTA reports from other countries. So it takes, it's important because we have to work on the transferability methods and to making sure that they're not using these reports and applying this in decision making without any other issues of transferability, adaptation of results, and of course it should be context-based and not simply brought from other contexts. So this is an important issue for future work. I just mentioned the second deliverable that was a series of case studies that we performed and on the use of HTA in the decision-making process. We defined 3 technologies. It was the trastuzumab, dralulinstant, and the HPV vaccine. And we chose Colombia and Brazil as the countries to perform the case studies, and comparing these in the region with Canada, with CADIF and the national agency and the Quebec agency. We don't have time, of course, to go into more details about the case studies. This is going to be available in the website. It's already in the Advance-HTA website. It's going to be translated to Spanish and it's already in English for being available in our website. We can have more details about this. Is all the framework on how we selected the technologies, what's the methods but I'm worried about the train that Panos has to catch. So let me mention now the toolbox. So the toolbox was the third deliverable, and we this is the first page. The objective toolbox was develop a toolbox, a toolkit target to emerging settings with the goal of improving decision-making process with best practices, concrete examples, innovative approaches. That so not only giving concepts, but in a very concrete approach, showing example, showing case studies from the, for example, from the mapping exercise, and from the case study that we performed the first and second deliverable. We use this to feed the toolbox, providing the best practices and hoping that it could be a useful tool, useful support to countries that are willing to use HTA or to start implementing HTA as a decision-making tool. So very briefly, I mentioned the 5 components: healthcare systems and HTA, building HTA functions, HTA products, using other tools beyond HTA, as Panos just mentioned, the multi-criteria decision analysis, and also implementing decisions. So I just show the main elements of each of the chapters. So type of HTA bodies, social values. In HTA products, we mentioned the various types of studies, that guidelines, transnational HTA, canonical evaluation, the use of multi-criteria decision analysis, and finally, implementing decisions, the use of practice guidelines, disinvestment decisions, and monitor and evaluation frameworks. So this is how we like the toolkits to be useful for implementing this integrated approach. Using HTA as one important input, and of course all the other elements that are important inputs for the decision-making process, and then as an output having the health benefits plans, and then all the rational use of health technology strategy to make sure that we have this feedback system when we can integrate all the different aspects in decision-making cycle, making sure that we can revisit the assessments, revisit the decisions, work on disinvestment, and also making sure that this could feed, there's a feedback also for regulatory decisions, and considering, of course, ethical, social, legal issues in this integrated approach. So we don't have time to go much more in details about it, but that's just to say that the toolbox, it was built considering this framework. So the most important findings, there's a lack of HTA capacity, especially in most of the Central American countries and Caribbean. There's lack of guidelines and standard procedures for the HTA, no explicit links between HTA and decision making, and no mechanism in place to monitor the implementation of the decisions. It is true that some of the countries have made important progress on HTA, building capacity, strengthening institutions, even creating HTA bodies. But in most of the countries, there's still no explicit links between HTA and decision making. It's important to develop tools for measuring the impact of HTA for health systems. We mentioned this morning about the issue of judicialization. Everybody knows about how important this is for the system in terms of, in some cases, creating distortion in the decision-making process. And definitely, you have a lack of implementation. And we definitely hope that the dissemination of the toolbox will help addressing this gap. Well, I think that's it. I hope this. Well, okay. So back to Nadia and Panos. Thank you very much.
I had to be very brief, but mostly I have to thank. I think it's a terrific work. I think we need a lot of time now to digest all the ability and to bring it back. And I hope we got a follow-up. So I just, from my part, it's saying that. I think we now have a platform to now advance into really bringing the implementation with these new perspectives of how health technologies can be incorporated into decision making in the Americas. So we're hoping for the chapter 2 of this collaboration. But take 23, yes.
I think projects of this type are fairly complex. I think they reflect genuine need from not only the member states that in the part of the planet that we live in, but also some of the sensitivities and some of the needs in this part of the world. And I think it's in an increasingly interdependent world, it's important to reflect on what is important, obviously from a European standpoint, but increasingly want to know and understand what the needs are in different parts. And specifically Latin America plays a very important role in this context. And I think it is great to have had the collaboration by PAHO to help us map the challenges, provide a mapping, but also construct this toolbox which drives the agenda for and makes HTA more approachable to a wider decision-making body. Looking forward to a take 2, hopefully soon, and it's an ongoing process. Thank you.